Hello, everyone. It's me again. I'm Professor Dr. Hao. I'm actually oral surgeon, orthodontist. I'm also a adjunct professor from Utah. Now, the last series of the YouTube, I was talking about why we can place implant within 5 minutes. All right, using the new digital and AI technology. Now, today I will need to talk about how do we know whether we need to do bone graft for the patient. So now, first of all, we look into the classifications of the bone loss pattern. So let's say if we have just extracted a tooth, then the bone is actually volume and thickness is at its maximum. But then if you did nothing about this one, we will continue to lose a bone that it get shrinkage in 3 dimensions. Then if you, and this usually happen within 2 years. Then 2 years later, if we don't do anything, it will shrink to this dimension. Then in another 2 years, which is total of the 8 year, it will become very narrow. So from 10 year onwards, it's going to be even smaller and then even reducing the height. And then about 12 years later, it will become almost all gone already. Okay, so therefore, we know that this is actually the bone resorption pattern, which published by Talmish and Judy in 1985. So this is actually give us an overview of whether how is our bone resorption pattern, and then how do we plan whether we need to do bone graft or not. All right. So now, if we look into a bone evaluation process, usually we have to look into it in 3D. That we look into it in the width, the height, as well as the length. All right. Of course, we need to measure where is the nerve, right? So, and we can do it in a way of using a model surgery. That means we take a stone model, or we can use it by a 2D X-ray, or we can do it with a cone beam 3D CT scan. All right. Yeah. So now, how do we actually decide how whether it is enough bone or not? Okay. So therefore, it's what we call a qualitative and quantitative evaluation. Qualitative meaning that by discretion, by eyeballing, by the surgeon's experience, and then quantitative is actually through measurement. All right. So now, if the nowadays what we're doing is more on a 3D basis. Why 3D is that when you look into a bone situation, let's say we know that the nerve is here, and the bone is here. So we can always avoid the nerve by putting it actually on one side or the other. And then, but from the 3D, it also tells us that the way we put the implant can be straight, or if we go deeper, we may actually penetrate through the lingual plate here. Or if we put it here, if we go deeper, then we may hit the nerve. All right. Or if we look at it this way, if we go deeper, then again it will hit the vessel and cause a lot of bleeding. And then if we go this way, it will actually be hitting at the side of the wall here. And therefore, how we look at it in the 2D and the 3D will be totally different, because there's a third dimension, which is what we cannot see. Either it's too inside, too near to the tongue, or too near to the cheek, or too near to the nerve. That actually is not able to see it from the model or from the X-ray. So we need a 3D to do that. And in the past, what we happen is that when we have a 2D X-ray, usually clinician makes a lot of mistake in terms of either the angle of insertion that they place it is actually not ideal, or they actually make a mistake because they cannot see the third dimension, so therefore there will be a damage to the nerve or to the blood vessel. And this is an example of a 2D X-ray. 2D X-ray. So what we used to do is that we trace it out, we put some teeth there, then we do the tracing of the jawbone and the teeth, And following which that we would then also do a tracing of the sinus. Yeah. Then we then trace the jaw outline. Okay, we trace the jaw outline. Then after that we trace the lower jawbone. Yeah. And then we trace the lower teeth. And then we then trace the nerve. Right. And after that we also trace the nerve such a vessel. So with all these things that we trace out already, then what do? We then have to then come up with this plate here, and we use a measurement template here to measure the implant size that we needed to place, and then we overlap into the x-ray. And with this way of doing it, then we put the implants inside. Now, this is actually what we have been using it in the past many years. So it is very scientific, very logical, but it's only 2D. So we cannot see the third dimension. And this is when possible mistakes or error could happen. And therefore, in order to improve the surgical safety, the surgeon will then have to cut the gum and expose the bone. So, and this is also another aspect that increasing the bleeding and the swelling incident. Now, how do we then reduce this sort of surgical morbidity? All right. So what we then do is that we can actually use a ball bearing here to then calculate the magnification factor of the nerve. Then we then measure this one, and then to measure the exact length compared to what is the x-ray with the magnification factor. Say for example, if we measure from the x-ray is 11.6, but the actual length is only 10 millimeter, meaning that the nerve is actually nearer in the actual position than what appears in the x-ray. So this is the reason why sometimes the clinicians may make a mistake. But however, with the new technology in the 3D, we don't have this problem because what you see is what you get. But here it's just I want to show it to you that in the past we use a model. This is how we go through all the step-by-step measurement, and then this is how we then build the precision. So therefore, we are actually measure everything with a lot of bone mapping procedure, and yet at the end of the day, we still have inaccuracy. But how do we overcome this problem nowadays? We use a 3D, and this is an example of the 3D CBCT. Where you look at it from this view is called sagittal view. Then you look at this one is from the frontal view, and you look at this one from the occlusal view. So what we then can do is that if we were to plan placing an implant here at this position, then we find that we actually have a problem that we may actually expose the bone. But we knew it before it happened because we have a software already told us that we cannot put in this way. Okay, so therefore with the simulation surgery, that we know that actually all this problem that we used to happen in the past with the digital technology and the simulation surgery, it is not happening nowadays because we will know it during our simulation surgery planning. Okay, AI will let us know. And nowadays, the technology has gone even one step further, that we no longer see things in black and white. The AI will help to color it. So it color in such a way based on the different density. For example, if it's just black and white, we have 256 shades of gray, but our eye cannot detect 256 shades. Our eye can only detect 16 only. So therefore, but if it's placing the color, it will be a lot easier for our eye to detect it. So we can say that we make the color sensitivity from the green to be the hardest to the black to be the least hard density. So from there, we can then make a simulation surgery, and then from all this color, it can tell me that which structure is a lip, which structure is a teeth, and whether the bone is a hard bone or soft bone, and which structure is a nerve, which structure is actually a blood vessel. So we can then now do a simulation surgery to accurately place the implant, and then the AI will tell us that the implant and the nerve and blood vessel relationship, and this is calculated to the exact dimension. So therefore, we don't need to recalculate the magnification factor again, and everything will be just what you see is what you get. And with that, you will find that the surgery planning is a lot more accurate than in the previously. Okay, so therefore, after we have done the simulation surgery, how do we then deliver it to actual surgery? That is actually the next YouTube that I'm going to share with you. But just to share with you that we actually have a surgical kit here, which will actually design for all sort of bone availability, from a very hard bone to a very soft bone, from a very thick bone to a very narrow bone, from without any bone graft to needing to do a bone graft, that we can actually design everything using our 3D digital technology, right, plus the AI. And if you like my program here, I hope you can take like and share and subscribe to my channel, and I will talk to you more about how do we actually do the surgery and how do we actually do a navigation technology so that our implant placement is very safe and risk-free. Thank you very much and have a nice day.